drugs and logistic, okay. Then records, documentation, then whether the guidelines are being properly practiced or not. Is that clear? So, first and foremost, for all these 1.5 days, we were brainstorming and learning more of guidelines. And here, for this session, we will know how to implement it as a public health program. Am I right? Am I right? Yes. So now coming back to the same question. So what kind of supervision are we doing now? Have we adopted now? Supportive supervision. Before going to the types of supervision, let's understand what is supervision. Right? I am just supervising you. I am just seeing what all people what are doing. If you are chewing Mentos, if you are on calls, if you are like interacting with me virtually also, I am just supervising it. I am just observing it. So we all know some part of the guidelines, right? Might be even I am not aware of between the lines or in the lines which is mentioned in some corner of the book. I will be practicing whatever I have understood. Only when cross-learning, intercheck by internally and externally, then only we get to know are you on the proper direction or not. Yes or no? Do you agree with me? So in that direction, supervision is more of observation. The system is moving, the program is running in the field. When I tell it's a field, might be it's a hospital, might be it's a patient, or a patient-centric approach, or the care what we are doing from the giving from the healthcare aspect. We are just observing it, right? Then, once the supervision is done, what are we then observing that in our report? We usually have that report after the internal evaluation, or when any consultant is with the health facilities or any part of a system. So what do we have there? Some kind of indicator, statistics. See, sir was telling, he was sharing that IMA experience, the knowledge is poor. As a public health specialist, I should understand, is that the voice of one single person? Can I generalize that statement? I need some data. Without data, for example, might be your officers, who is superior, like your reporting officers or your bureaucrats. When you go and address, sir, the doctor is not at all functioning properly. Is it the right way? Or that lab technician is not at all doing proper smear. Is that the right way? So what are we telling? We have observed that the system is not good. But then, it's not only a negative, we should also tell about the positive aspect. That lab technician is really contributing a lot to the system. That SPS is really giving a patient-centric approach. It's not just he is my pet, so like very friendly, I can give this statement. But that should be supporting with evidence, right? Yes or no? But one important line to be underlined and checked again and again. The data is one which helps us to move in the right direction. Just to show that we are in the right direction, the data should not be generated. Right? So next coming to when we are supervising, we understand some indicators are not good. Might be the lab positivity rate is very poor, or the smear positivity rate is too less, whereas when subjected to the NAT, we are getting 30-40% positivity rate. This scenario made, the smear positivity rate is very low, whereas the NAT positivity rate of the same geography, of the same patients who are like giving the samples to that DMC, it is high in the NAT. What do you understand by this? It is just my observation in one of the TU. What is your understanding by that? Sorry? Smear report is not good, one possible way. Then? Technical staff, the lab technician officers are undertrained. Then? Overwork, overburden. So these are the possible things. Then I have to evaluate how many smears he is checking and what is the logistic he is using. Is this near expiry or outside the expiry? So between the lines, everything has to be checked. So that's when I supervise, these are the observation, I just observe it, right? And next comes the monitoring system. We got to know that this lab has more capacity on improvisation. So how am I doing it? I develop my monitoring indicator. When I tell it's an indicator, there are three types of indicator: input, process, and then output. We can't just tell in a public health may, we can immediately get an action just by the sensitization, just by the circulars. We have to monitor it. We have to monitor in every step. Am I right? So in that scenario, for example, we tell the MDR-TB notification rate in one of the geographical area A is 2 per lakh population, right? Then we got to know that NAT, what is being diagnosed, the completion of the diagnostic care cascade. Yesterday we had a detailed discussion on the new algorithm, new and important algorithm, how we are subjecting with the diagnosis along with the treatment part, right? So we got to know that many of our patients is not subjected for the NAT. So this is the bottleneck. So what am I supposed to do? Identify the appropriate presumptive TB. Identify the vulnerable population among whom the TB is very high. Might be, for example, a diabetes patient. Then even a single day cough is taken as a presumptive, right? So bring out your working population, the cohort population, and then try for an upfront NAT. Then, when you challenge before system and after system, do you get more positive rate among these this vulnerable population? When you subject a vulnerable TB population for screening of the disease, do you get the positivity rate as high? Yes? Now do you feel that my smear positive rate is high? Yes? And this will be supported by training of the lab technician officer, appropriate logistics, and internal check with our STLS, visiting there. So these are the activities I have done to increase my monitoring indicator, that is positivity rate at that lab, might be a smear or NAT, whatsoever, in that respective geographical area. So when I tell monitoring indicator, that will not again jump from 1% to 10% immediately. If it jumps, no, somewhere I will be starting thinking, something is wrong there. Should I think or not? It's bad to be too good. I repeat, it's bad to be too good. If my TB fatality rate among the notified is 1%, right? And loss to follow-up is 0%. Success rate is 95%. That is where I do visit there. Do you agree with me? Why? Why? Might be. See, I don't tell something wrong with our own stuff. It's like without knowing some things are being done. For example, in field I was like 5 years there. So suddenly the MDR-TB cases were like where we were expecting hardly like in 3 months with just 1 or 2 patients. Suddenly we got 22 patients in a month. 22 patients. Rifampicillin resistant detected. That alarmed us. So when we got to the site, we got to know that lab technician officer was deputed from other stream, and for everything it was like yes, karke, she just moved ahead. So that's how we got 22 MDR-TB patients in that TU where we expected 1 or 2 in the 3 quarters. It is not like, okay, I should increase the MDR-TB. No, no such intentions. So that is why the supportive supervision is very, very important to back up the monitoring indicators. Am I clear? So supervision is just observation. Monitoring is whatever the bottleneck is identified has to be cross-checked with the data where we'll define the numerator and denominator appropriately. For example, I guess 11 states and union territories are here. Excuse me, ma'am, let me complete this session during a tea break. We can take this process, please, if you don't mind. Thank you. So further, coming to the evaluation. What is evaluation? What is evaluation? Sorry?
To find out whether we have achieved the objectives.
To find out whether we have achieved the objective. Okay? Then? It's after the complete procedure, at the end of the day, we look at this evaluation. It might be an internal check or an external check. Am I right? So we call it as an internal evaluation, might be a district internal evaluation. Few districts are pro in that, and state internal evaluation, and we also have a central internal evaluation. All are internal checks. Also, we do have a third party, that's an outsource. External check is also being done to just see whether we are in the right direction. So with this background, is this clear? These three concepts are very, very important. And again, we have defined in the PMDT guidelines in the annexure what are the numerators and denominators. This is just a standardized thing. Like now we have about 11 states and union territories. Delhi may come up and tell that my case finding activity is too high, my notification rate is too high. And the next person, the SDO from UP, so may come and tell that, no, my notification is too low. But when I check it, this state is considering based on the diagnosing cohort, whereas this state is taking on based on the current cohort. What is the difference between diagnosing and